All right, well, we will go ahead and get started. So good morning, good afternoon, and good evening, everyone. Thank you for joining us for our February of 2021 Global One Health Initiative webinar supported by the NIH Fogarty International Center. Our theme for this webinar will be One Health, Community Outreach and Engagement Activities. And we will be hearing from speakers, Dr. Susie Breitenstein from The Ohio State University, speaking about the Community Health Care Worker Training Program, and Dr. Sanja Ilic, also from The Ohio State University, speaking about her work with education and outreach surrounding food safety in local communities. So I would like to go ahead and briefly introduce our speakers before they begin each of their presentations. And I'll start with Dr. Susie Breitenstein, who is an associate professor and director of community outreach and engagement, as well as the Community Health Worker Training Program at The Ohio State University College of Nursing. Previously, she served as an associate professor and associate chair at Rush University College of Nursing in Chicago, Illinois. She was a Robert Wood Johnson Foundation Nurse Faculty Scholar and was elected as a fellow in the American Academy of Nursing and National Academy of Practice. Dr. Breitenstein has served on numerous grant review panels for the National Institutes of Health and the Office of Planning, Research, and Evaluation in the Administration for Children and Families. Her clinical expertise is in child and adolescent psychiatry and group-based behavioral change interventions, and she is best known for her work in promoting positive parent-child relationship and preventing behavioral problems in young children from low-income neighborhoods. Dr. Breitenstein has been involved with the Community Health Worker Training Program at Ohio State since 2019 and has developed the program and evaluation structure, curriculum, funding, and workforce development structures and pathways for the program. So with that, I will go ahead and hand it over to you, Dr. Breitenstein. You can share your screen.
Sorry, I can't find my mute. Yeah, you start having too many screens open. Thank you so much for the invitation and opportunity to talk to all of you about our Community Health Worker Training Program. As Laura said, I have been involved with the program for about a little under 2 years, and I've had a pretty steep learning curve. My research has been primarily with mothers and fathers of young children in the community, and I got involved with the Community Health Worker Program more on an evaluation standpoint, but then I got more involved in the curriculum and got really interested in it, and so I'm really excited about this program and to share the information with you. So I'm going to talk about our program, but I'm also going to talk about the role of community health workers in general, and I'm going to present a little bit about what community health workers are doing related to the COVID pandemic too, and then about our program. So there are lots of titles for community health workers, and community health workers have for over a century acted as agents of social justice and healthcare promotion and change for under-resourced communities they serve and come from. And they, I like to think of them as with and of the community. So they're frequently individuals from the community, and so they have intimate knowledge of the culture of the community they serve. And this is so important in the US and globally because our healthcare systems have done little, but I think it, in certain sectors more to build trust with under-resourced and marginalized communities. And community health workers are unique in the fact that they are already part of the communities that they're trained to serve. And so they really act as a go-between for the community members, healthcare organizations, and social service agencies. And that established relationship and rapport in their communities are really critical in serving as trusted community members to improve access to healthcare and healthcare outcomes. They're often employed by public health departments, federally qualified healthcare centers, primary care, and community agencies. And the World Health Organization has really done a lot of work globally with community health workers and expanding the role. That's not an area that I am expert in at all. I've done some readings around it, but there is a lot of interesting work globally using community health workers as kind of mid-level paraprofessional outreach workers. So I like to think of CHWs as a liaison link or intermediary between health and social services in the community. And so they really help with navigation for resources, for access, and for care. Another way to think about community health workers too is thinking, and I wasn't quite sure what the audience would be, so I apologize if this is basic, but community health workers really are key in addressing social determinants of health. And so just a little background in terms of social determinants of health are conditions in the places where people live, learn, work, and play that affect the health and well-being of communities and also contribute to a wide range of, health risks and health outcomes. And when working with a patient and coordinating services for them, the community health workers really can walk through the social determinants of health and to think about where there are gaps and needs and what a community member might need in order for them to succeed moving forward. And again, either related to the services that they need or health behaviors that they need support with. And community health worker education is rooted in the social determinants of health and how these different variables create both barriers and opportunities for resource access, information, and also opportunities. And they're trained to help identify these and then assist in navigation. And so even in our program, we think about this health very globally. And so the community health workers are really supported in thinking about resources in terms of both, from an educational perspective for the clients they're serving to employment. And so all of those resources are important to help support patients and in thinking a kind of a global approach to the health of the communities. So in terms of roles and responsibilities, these really vary. And part of why it varies is there has not been, CHWs have been around for a long time, but there is not a clear definition of role across the nation and globally. But really, again, they build on individual and community capacity for increasing health knowledge and self-sufficiency. They'll offer interpretation and translation services. We have a faculty member in our College of Nursing who is doing a lot of work with the Asian community in Columbus, and she uses community health workers in part of her research project in terms of cancer risk screening, and that she has worked really closely with these community health liaisons because their intimate knowledge of the community and language has been really important to help provide health education. They provide culturally appropriate health education and information, obviously, as I have described, and help people get the care they need. And there's also partly guidance on health behaviors and informal counseling. They're not direct service providers, although we do train them to do some minor first aid and blood pressure screening that helps kind of with the connection between the healthcare system. One thing that's important is that public policy really supporting the growth of the CHW role, and this goes back to kind of role definition, has lagged behind, although there's been an increased demand for CHWs, again, locally, regionally, and nationally. But in the United States, only about a quarter of the states actually have laws that govern certification of community health workers, their scope of practice, and also reimbursement structures. And that's been a big challenge from a policy perspective in terms of how CHW's work is reimbursed. It is improving, but in Ohio, we actually, our community health workers are certified through the Ohio Board of Nursing. And that's different from other states. Other states might have certification through professional organizations or other certifying state boards. So I would really argue that consistency in state legislation and certification policies would really help both clarify the role of community health workers, but also will help with reimbursement structures, but also encouraging communities to engage with these individuals in terms of part of the healthcare team. So a little bit about community health workers and COVID. So CHWs really serve communities that we know are disproportionately affected by COVID-19, low-income communities of color, and the homeless. And so I see community health workers as a key partner in helping prevent both the spread of the disease, but right now we've been obviously focused on looking at uptake of vaccination. And as COVID-19 has become, the vaccines become more available, we're seeing a lot of misconception and mistrust about the vaccine. And I was looking at some statistics, and these were from December, but there was, I think in December of 2020, and the more recent ones I think have improved as uptake has continued and people have been becoming more knowledgeable about the vaccine. But in December, only 60% of Americans reported that they would get the vaccine, and almost 40% probably wouldn't or definitely would not. But I think what is compelling is there's a racial difference related to intent for vaccination too. And so again, this was from late December, but 42% of Black Americans, only 42% reported that they would get vaccinated, compared to 63% of the Latinx and white communities. So I think one of the things, because vaccine hesitancy is so complex and really rooted in mistrust of healthcare systems and research and development and newness of vaccines and worries about the side effects, and I think some of you have heard other wild misconceptions about being implanted with devices. I think this is a really nice place for CHWs to enter in terms of their role, and that they can really bridge that divide, boost confidence, and contribute to informed choice. So I think the idea is that we're not forcing vaccinations, of course, but to be a trusted voice and advocate to the communities that they serve, that their answers will be, their questions will be answered, but also they'll have more confidence in getting the vaccine. But I also, I think there's a disparity in the CHW's access to vaccinations for themselves too. And many of them are frontline workers, but I know that in some places they're not considered frontline workers, and so they haven't been, the vaccine has not been available to them. And so I would argue that that's something that needs to be looked at too, in terms of their ability to get the vaccine and then to support the communities they serve. So a little bit about the Community Health Worker program at The Ohio State University. It has been around since 2014 and was originally funded through various city organizations there. And right now, some of the programs is funded through Franklin County Jobs and Family Services as a workforce development program. So we're able to offer the program free to individuals that meet criteria for that funding source, which is they have to be TANF eligible, which is TANF is the Temporary Assistance for Needy Families, and or we have funding through Title 20. We also are able to accept anyone who is able to pay the tuition too, and we're looking for other sources to help support funding for this because community health workers are with them from the community. They often are also part of that underserved and marginalized community. And in our program, we provide instruction and resources really to try to build this pipeline of professions. But we're a workforce development program, so we're building CHW workforce, but we're also focused on people and skill development. And so we take this from both like a place-based perspective where we address the needs of the people living in the communities, but it's also this sector-based focus on trying to match skills to the needs within the area. Just in terms of our program, since 2014, we've trained over 300 individuals in this to be community health workers, and that have been certified by the state as community health workers. Let's see what else we have. We in the program, it's a 14-week program. It's 104 hours of didactic. We really have an amazing team who runs the program. We have a public health nurse from from Columbus Public Health, who is our main didactic teacher. And then we have a trained community health worker who works with us for the practicum placement. So our students also complete 130 hours of direct practicum experience within local healthcare organizations or social service agencies. And so these two are really the key to the program in terms of their connections with the community and liaising with the community. The students, in 14 weeks, that's not a long time. So there's a broad overview of health systems and care. But another big piece of the program is really around professional development and communication and resources and resource management. And so that's the big piece, is trying to help the community health workers and trainees to kind of learn how to search for systems and resources, and also to communicate across the sectors they're working, both within the community and with the healthcare system. We have started working with our improving some of the evaluation components of the program, both in terms of our student competencies, but also we're starting to look at how to track student work attainment and further education and other program impacts, even as far as the health of the communities that they're serving. As you can imagine, getting this data is challenging because once they graduate, it's hard to catch up with people. And so this is a slow process for us, but I'll actually put the pitch out. If anybody's interested in this kind of work, let me know, because I think it's right for evaluation and research. And we don't have a ton going on right now, except what we're doing internally. I think one of the biggest things we found of our graduates over the last year is that 81% were reported that they were planning for future education in healthcare, so in nursing, public health, community education. Some were interested in CDCA, which is chemical dependency certification. And so I think that's really important too, that this is a pathway into other healthcare jobs as well. And that is all I have. This is just some of the sources I used and some resources that I was looking at for both around COVID-19 resources that community health workers can use.
Thank you so much for a wonderful presentation. Such highly relevant points, and I'm sure there'll be excellent discussion. Again, we will hold questions for the panel discussion afterward. And now I'd like to introduce Dr. Sanja Ilic, who is an associate professor of human nutrition in the Department of Human Sciences at The Ohio State University and a food safety state specialist. She investigates transmission and dissemination routes, interventions to prevent risk of microbial contamination in foods, food safety behaviors to determine barriers to food safety interventions, and works to promote food safety among consumers, food handlers, and populations at risk. Her research investigates novel interventions to control and eliminate foodborne pathogens to improve consumer health and wellness. And Dr. Ilic has a special interest in microbial safety of fresh fruits and vegetables, working with Shiga toxin producing E. coli, Listeria, and Salmonella species, among others. And Dr. Ilic is highly involved in GOHi activities. And with that, I will hand it over to you, Dr. Ilic.
Of course. Hi, thank you, Laura, for your introduction, and thank you for inviting me to talk today. As you have heard, I study food safety, and I'm also a state specialist. And my role as a state specialist here at The Ohio State is to take that research from the labs and research from evidence that is generally available and turn that into, translate that into some sort of outreach or extension to the end user. And as Laura mentioned, I work a lot with the produce grower, with the consumers, and basically on every step through the cycle of the food. But today's talk is going to be about face masks and their effectiveness to prevent COVID transmission. And I'm not a virologist, but when this pandemic started, there was a great need to communicate about the ways that people can, consumers and the community can prevent transmission and can protect themselves from the virus. There was a lot of confusion on the intersect of food safety and COVID transmission. And as a state specialist, we had to jump in. And also, if you remember at the beginning of the pandemic here in Ohio, that was sometimes in late February, there was this recommendation. Let me just remove stuff from my screen. Okay, there was this recommendation that people should not wear masks. That came from the officials, that face masks may not be needed or required to prevent transmission. And this was with the goal of preserving personal protective equipment for the frontline workers. Still, it caused a lot of confusion, and the understanding among the community that face masks are actually not effective. Obviously, a year later, we not only have the recommendations that we should be wearing masks, but also just last year, this MMR from CDC was published saying how the maximizing fit for cloth and medical procedures could improve the prevention, and there has been annexed possible recommendations that the masks, double masks, could even reduce exposure. So that there's a change of recommendations to the community, with actually the evidence behind it has not changed. But just to remind everybody that, and everybody on this call is familiar with this, that the diseases are actually going to be dependent on the pathogen, host, and environment interaction. And on pathogen in this COVID pandemic, we already know, although it's a new emerged pathogen, but we already know a lot about it. We know how it is transmitted. We know we have already developed some vaccines that are being used. On the host side, we know that different risk factors like age or underlying conditions may make somebody more susceptible to developing COVID-19 or in developing a severe form of the disease. And also on that host side, many times to prevent the disease and to break this line between the pathogen and host, we rely on human behavior. And relying on human behavior requires understanding of the processes involved in behavioral change. Obviously, environment in the macro level and micro level is important in transmission. And for us, there was a lot of discussion around when back in August, when the kids were supposed to go to school, how we can prevent that environment from becoming saturated with the virus and causing more disease and more spread of SARS-CoV-2 virus. And so, as I said, we know a lot already about virus. We know what the symptoms are, and we have developed numerous vaccines. We also know that there is this a mutation that occurs, a 20 gene mutation that makes up 2 new varieties of the virus that are currently spreading from South America to UK. Now it has been found in India. I want to share with everybody this it's here, this article that is produced by National Geographic Science. It is actually listing and describing each available vaccine. And I'm hoping that information there is really well summarized, and it's been updated, and that information there can really help us develop more education surrounding the vaccines. As Susie mentioned, the education is really important in behavioral change and acceptance of the people towards a vaccine. But until we all get vaccinated, and it's going to take a minute, we need to keep preventing the transmission of the virus, right? So just to recap, the virus, respiratory virus, transmits through close contact via droplets. When droplets are expelled, directly land on another person breathes them in, and they become sick. Airborne, when the virus expelled from an infected person gets intermingled with dust particles, other particles, flies through micro droplets, and another person gets exposed, breathes it in, and gets sick. And the fomite transmission, in which an infected person expels the virus on the inanimate surface, and then the next person touches inanimate surface, breathes in the virus, and gets sick. So each route of the transmission is basically expulsion of droplets, and those droplets are going to the next person and gets them exposed and gets them sick. So droplets. It is really important to prevent those droplets for getting to the next person. And we recommend in the community that wearing face cover would prevent those droplets from getting micro and macro droplets from getting expelled into the environment and to the next person. And we recommend the 6 feet distance. We also recommend hand washing to prevent that fomite transmission, but the majority of transmission still is via droplets through airborne or direct close contact. Okay, and we know a lot about how droplets move. Dynamics of droplets has been very well studied, and not only for this SARS virus, but also for the viruses like flu virus, etc. That the diseases that are very well known and studied. And so this is one of the models on how droplets move, whether they're stationary in a stationary environment or when there is some wind. There are these the cloud of droplets that moves from a person to approximately 2 meters, where the majority of those macro droplets discharge, and then micro droplets can fly as far as 6 meters or 8 meters. Some studies have reported, or 24 feet. Okay, and so this brings me to the study that I have recently performed with a group from Case Western. So when we were late February, early March last year, we were discussing, there was this recommendation that face masks should not be worn. And me as a state specialist, I was asked about that recommendation, but I had no data to back up my I knew I could not recommend, yes, please wear surgical masks because there was shortage, but I had to, I knew that face masks were effective, and that is obviously, face masks have been worn to prevent the droplet transmission since forever. So, but there was no data to show that fabric, the face masks made from fabrics were actually effective, and which fabrics were more effective, which ones less. So we set on to do a quick study and evaluate effectiveness of textile masks to prevent the transmission of virus. We have modeled the virus expulsion and used designed a very simple experiment using a spray bottle to simulate the sneeze. And I'm going to show you here this also model from MIT that we used to validate our spray bottle. I'm just going to quickly here exchange the screens, and that can be challenging sometimes. So just bear with me. Here, these are infrared images and the video of a person sneezing and how the cloud and droplets are moving. In this one video, the first video, a person is expelling the cloud of droplets, and then the second video is showing the same thing in slow motion. And using those measurements, we have validated a spray bottle that we could use in the lab to validate, test the effectiveness of interventions. I'm just going to now stop this share. So yes, and I hope we're back in business here. Yes. All right, so so for this experiment, we used a specific nozzle that is giving us that gave us enough pressure and the distribution of droplets or particles that are expelled from 200 to 900 micrometer, with a peak at around 70 to 100 micrometers, and that was similar to a human sneeze. So from there, we made a suspension that it was supposed to simulate the sneeze or cough, and we needed something to visualize and to enumerate the droplets. So we used the bacteria. We actually made a suspension of 12 probiotic containing dairy. It was a kefir that we used that contained around 10 to the 7th of microorganisms, bacteria, and yeast. And then we also used 25 milliliters of saliva with around 10 to the 7th CFU per mil of microorganisms, and we diluted that in 900 milliliters of PBS. So that kind of gave us the consistency of the human excretion. We sprayed the simulated sneeze onto the line of blood agars, and then we counted the droplets. And so first we looked into the droplets expulsion of droplets with no barriers. So we were able to count the microorganisms or those macro droplets at the distance that was further than 6 feet. So it was over 180 centimeters, but the majority of them did discharge at 180 centimeters, which is around 6 feet. And here you can see the spray, several spray simulations that we did with no barriers. And you can see how this graph here represents the macro droplets. So you can see the macro droplets, how they discharge the majority of them at the distance of around 60 centimeters, and then fly all the way to 180. On this side, you can see the micro droplets, and you can see that the majority of micro droplets also discharge that we were able to visualize were discharging at around 60, and then smaller amount towards the 180, and then they would fly further than that. So in practice, if a person sneezes, here you can see up at the top, the spray would, and there are several people in your line, let's say in your grocery store, the cloud would definitely reach several people, and they could possibly be exposed. Now here, if we use a barrier, what we find with a textile mask, the reduction of droplets at 90 centimeters would be around 75%. If the barrier and the reduction of the droplets right in front of the person would be around 99.7%. Okay, and so we tested 6 different fabrics that were used in that are commonly used in a household. We tested those fabrics to understand how effective they were in preventing the transmission, and whether all fabrics are equally effective. And so now, you know, in the stores you can buy all sorts of face masks from different styles and different type of fabrics. But at that time, you wouldn't be able to find anything, and people rely on what they made for themselves at home. So our question was, are the fabrics homemade face masks effective, and whether all these textiles, all these fabrics are equally effective. And you see, we tested it here with no barrier. So that was our control, non-textile control. And then we tested the medical surgical masks, and also we tested the surgical drape. And we used these two as a gold standard. So ideally, we want fabric made mask to be as effective as surgical masks. And so we tested several types of cotton. One was 100% comb cotton, 140 GSM. The GSM means grams per square meter, and that's usually what is used as a quality of textiles. So it's a weight of textiles. Then we tested 100% polyester, 300 thread, then a homespun cotton 140, homespun cotton 115. Those are a little bit lighter fabrics. And then 100% polyester, that is the dry technology material that is used for exercise jerseys, for sports jerseys. And what we found here is at the bottom axis, the x-axis, you have the distance from the simulated sneeze or the spray, so in centimeters. So between right in front of the mask and 30 centimeters far. And then here at y-axis, you have colony forming units per plate, per Petri plate, which is here stands for colony forming droplet units. So this was our way to count the droplets, basically. And you see that that surgical masks pretty well contains the droplets, and so there were only few at the first plate, the closest distance, and then only a few we were able to measure at 30 centimeters. And you see here, one layer materials did contain some droplets at the longer distances, but not that many, especially not that many at a very close distance. And then you see here at the bottom that 2-layer material fabrics were able to very effectively reduce the droplet transmission. Okay, here you see the medical surgical masks and the 2-layer cotton t-shirt had a very similar droplet retention effectiveness. Okay, and this is linear regression model when we actually measured the slopes or effectiveness of these fabrics to retain, to prevent the transmission of droplets. And you see that the lines that are closer to 0 are the fabrics that are more effective. And here you can see that the most effective fabrics that we found were 2-layer cotton t-shirt material type, so that 140 comb cotton fabric, and then a 2-layer dry tech sports jersey. Okay, and so as going back to our model of infectious diseases, it is important that we know what type of fabric is more effective, but it is also important that people can breathe when they're wearing 2 layers of something. So here we measured the transfer of light through the fabrics to kind of approximate how breathable the fabric is going to be. And the red dots here present all the areas that in the fabric that transmit the light or would allow for braiding. And you see here that comb cotton t-shirt 140, the one that was most effective, together with this polyester sport jersey. You can see that cotton is much more breathable and probably would be much more comfortable to wear. These are here the controls. So surgical cloth and surgical mask are pretty breathable as well. Okay, so this is what we saw in our lab. And we knew that this is going to be globally important, not only for the audience in the US. So we in particular did not call the fabric effectiveness, we call it textile effectiveness, because we knew that the majority of other languages and other cultures, the fabrics are actually referred to as textiles. So we call, this is how we titled the paper, to make it more accessible to people that are searching this research globally. But one thing is what we do in the lab, one thing is what it happens in real life, and human behavior has to do a lot with it. This is just to illustrate that in this systematic review, they have found 172 observational studies, so using data, real data from healthcare, non-healthcare settings, and among those 44 comparative studies were systematically reviewed. And what they found is that the physical distancing of 1 meter or more and use of face masks and eye protection was the most effective in preventing the infection among over 25,000 patients with COVID-19, SARS, and MERS. And so I included here the paper for your reference. Now, the outreach component of this, it is good. We know have this knowledge, we have published. Some people are going to look into published papers, but majority of our community are not going to see the research unless we actually make it visible and translate it into the way that can actually serve as an education for our community. So what we did, we thought this was a very simple experiment, actually, that we possibly could translate into a STEM piece for students K to 12, but also for citizens. And we have partnered with people from Kent Western University and have developed an educational module containing 4 experiments that are describing the distance to which the droplets can fly, and the effectiveness of fabrics and effectiveness of face masks to prevent the transmission. And so here you have a little insert on it, but I included the citation, the link here to the full paper. This educational module is available as an open access, and to produce it, we have also partnered with researchers affiliated with WHO, and we have translated this educational module into French, Portuguese, and Spanish. So it is available in these 4 languages: English, Portuguese, Spanish, and French. Okay, so who are we now missing as our global community is dealing with the same thing at the same time, and this kind of research is important, and this kind of education is important pretty much to everybody globally. So this is also how the experiment educational module looks like. So you can look it up online. It is available as a PDF for everybody to see. So the group of marginalized often group of in our community that is often that cannot use an education module like this are blind and visually impaired. For the blind and visually impaired, there was at this point, and this was just in August, just before the schools are starting, there was nothing for the teachers to use to teach, or for the blind community to learn about COVID-19 and preventive measures. So previously, I have worked with Dr. Tiffany Wild here from the Ohio State from Education Studies to develop this health education guide for visually impaired and blind. And there is a section there on infectious diseases. So we have even actually gotten an award, Warren Bledsoe Award for this publication. But of course, this was just before COVID. It was published in 2019. So there was nothing about COVID. So we went on to adopt our educational modules for blind and visually impaired, and develop this module for teaching the students with visual impairments about COVID. I'm very proud of this one. It also consists of 4 experiments that are completely adopted for visually impaired and blind, that is using the tools for special tools for visually impaired and blind, and then using these homemade materials that can be available for communities at home, but also for schools, and they're readily available, like a cereal box and this cupcake molds, etc. And so, we made a model of COVID-19. One model is very hands-on and very easy to make, push pins in the orange, and really looks like COVID. And the other one is actually a little bit higher tech. So it's a file that for a 3D printer to print a COVID model like this. It's very tactile. We included a section on explaining to visually impaired and blind what 6 feet distance looks like, and then the full-blown experiments with these homemade Petri plates, whether you're going to use Be My Eyes or ERA application that is also going to be training them in independent living skills. And so to wrap up, the masks are only as effective as if people are wearing them properly. And then again, here we partnered with NC State Extension to produce these fact sheets for everybody, how to properly wear and care about your face covering, and obviously more information about hand washing, with addition to 60 and 70% alcohol-based hand sanitizers. So this is all that I had for today. There is a whole COVID-19 education hub that is available from the Ohio State University. There are numerous YouTube videos, webinars that we have already produced on this topic, and especially the link between food safety and COVID-19. And I invite you to please have a look. And that's all I had. Thank you very much. And this is my email. If you have any questions or need any materials, please just let me know.
Thank you so much, Dr. Ilic. Again, such critical work and excellent points to discuss from both speakers. And with that, we can go ahead and open it up. If you could please send your questions via the Q&A box. And it looks like we already have a couple questions. So starting with, we have a question from Dr. Sleshy Wolde Gabriel. If a person is infected with COVID-19 under natural circumstances and recovered from that disease, is that necessary to perform vaccination for that person? And did you perform serological tests before providing the vaccine? Thank you. So I guess that would be directed to either speaker, and I'm not sure if we have a direct answer for that, but I'll let you guys go ahead and take it.
Susie?
Well, I know the first answer is yes, they're vaccinating any individual that has had contracted COVID because they don't know how long your immunity maintains after that first exposure.
Great. All right. And then it sounds like serological tests before providing the vaccine that's not being carried out, I don't think so.
I don't think that's done. Yeah.
Okay. All right. Thank you. Our second question is from Debasu Gela. The mask effectiveness study is very interesting, isn't an interesting study. My question of curiosity is how could the probiotic organisms or bacteria be used to simulate the viruses, which are much smaller in size? That's the first question.
Okay.
You can take that one.
Okay, I'm so glad you asked that because it's an important question. Yes, we were not, we did simulate. So we know that when we expel various viruses during sneeze and cough, we know that they don't fly individually. They fly in droplets, and those droplets contain our saliva, and they contain other microorganisms from our mouth or nose. And so we use those other microorganisms to simulate the droplets, to actually be able to, not to simulate the droplets, but to count the droplets. Because we know that virus is not going to grow on a plate. It requires human cell or host cell to replicate, but the bacteria or the yeast is going to grow and give us a very simple way to enumerate the droplets. So we enumerated the droplets, and we're assuming the droplets would have the virus as well. So we never enumerated viruses, we just enumerated the number of droplets.
Great, thank you. Then to add to that, do you think the time the virus remains suspended in the air is comparable to the time the bacteria would remain suspended in the air? So
it goes again to the same point, right? So the virus or the bacteria or whatever is in that droplet, it's virus, bacteria, yeast, whatever we have in our mouth, including saliva, depending on the size of the droplets, they're going to be suspended in the air in different amounts of time. So once we sneeze, those larger droplets, they travel shorter time, but they carry more material with them, whether this is actual saliva, this is bacteria, or this is virus, whatever is in the droplet. And those little droplets, they can travel far, as I mentioned, up to 24 feet.
Great, thank you. And I think this last question is along the same lines, but how about the pore size of the mask versus the virus and bacteria size? So I think you
Yeah, yeah. So viruses and bacteria are really small. If we had to wear masks, right, to actually account for that have filters to filter out according to the bacteria and virus size, those filters would be really tough, right? And it wouldn't. It would require very different structure of the mask or that different filter. But with face masks and with surgical masks, what we're achieving again, not individual bacteria and virus to be stopped, but actual droplet, right? And we said the droplets are a little bit larger and they carry many of the viruses, bacteria, and saliva. And so we're stopping those.
Excellent, thank you. And it looks like we have a question from Dr. Cabrera as well. I'll let you go ahead and speak.
Just a quick question. Thank you so much, Sanja and Susie. This is really wonderful, both behavioral, educational, outreach parts, but also supported by wonderful science. Sorry, Laura, I couldn't type in Q&A since I'm a panelist.
No problem.
So I'll just ask by voice. So very much appreciate it. So a couple of questions. One is, with all this information and knowing the science, how much is the science, this really great science, like in Sonia's case, you provided lots of in-depth presentation, gets into the communities, and how do you make it really palatable to the community? And secondly is, behavior and education is a critical part of changing public's behavior, which is wonderful to hear from both of you. At the same time, there's a complacency when people are knowingly or with a limited knowledge do things. Do you have any tools to modify that kind of behavior? And I'm asking from global context, right? Locally here in Ohio, as well as, there are many participants in different countries with different, population and in complacency or acceptance compliance rates. Any comments? Thank you.
Yeah. Thank you. Susie, do you want to? Or
yeah, well, I mean, I know, I think, behavioral change is one of the hardest things. And I know in Ohio, the Ohio Department of Health is really trying to work with a lot of individuals are involved from our university here at Ohio State, but across the state in addressing some of the concerns around, I think, both the behaviors around protecting yourself and the vaccine hesitancy. I think a lot of the work is trying to be done kind of at a grassroots level too. There is a large, as I noted, we have a larger gap in terms of interest in getting the vaccine in the African American population. And so there has been a lot of work in the community, working with faith-based leaders and making sure that the messaging and the information is coming from individuals that the community can connect with, that they feel that is trusted. I'll put this in the chat when I'm done talking, but I also know that the Department of Health is holding town halls too, with various ethnic groups in terms of making sure that they're addressing their needs and their interests. And the complacency thing is kind of an interesting question, and I don't know the answer to it, because when I see, when you see someone with their mask down here and walking through the grocery store, I think Sanja could probably say, like, that's not going to help much of anything.
Yeah.
Like, it's like, you might as well just take that mask off. And I think, I don't know how to reach those individuals either in terms of the messaging, because they're getting similar messages. They're making some personal choices too.
Yeah. So usually when we talk about health education, we say we have to tackle it from three sides. One is general education, so educational materials and educational campaign is one thing. And then the second thing would be some sort of behavior change intervention. And then the third thing would be force of law. So basically requiring businesses in the case of these face masks, etc., requiring that the masks are worn and they're worn in a certain way. So these are three options. Educational pieces are those fact sheets that I showed some, and then behavior change. Usually when we talk about behavior change, we base the behavior change intervention, base it on a theory, right? And there are several theories, like health belief theory is one of them. And then those theories, they propose different constructs that affect behavior change. And those constructs have to do a lot with environment, and they have to do a lot with self-efficacy, like Susie mentioned. Their trainees are evaluated on the basis of their confidence, so their self-efficacy to conduct new behavior, etc. And new behaviors are much more easily accepted if they're very similar to our old behaviors. Now, wearing masks is not something that is culturally acceptable here in the US to begin with. So there's going to be a lot of resistance to that behavioral change in general. Also, public health and being invested in public interest is not in the culture here in the US. So there is going to be a lot of resistance. Not only that is not in the culture, but it's also politicized as some sort of socialist, or it's labeled as a socialist agenda or something like that. So all these going to affect how a certain intervention or how behavior change is going to go. It was much easier, for instance, in some countries in Europe to accept wearing masks because there were less or different kind of barriers, but maybe there are some different behaviors that were more difficult to implement. So they're really understanding the target population to develop this intervention is the best way to kind of produce that behavior change quicker.
Yeah, I would agree. And I think it's the challenge, right? Because this has been a rapidly changing thing we're dealing with. And so to be able to kind of think about these independent individual groups and what the messaging needs to be for those groups is, I think, part of the challenge. There's not one message.
Yeah.
Like you said, kind of the good of the public is an incentive for some of us that oh, okay, of course I will now wear a mask, but for others it isn't. And so kind of individualizing and adapting those messaging is challenging.
Yeah.
Excellent, thank you. And we have a question from Dr. Barb Kowalczyk. Has anyone looked at why people wear their masks, I guess sort of the halfway up, not all the way?
Yeah.
Why they wear them that way?
So we try to address a little bit the breathability argument from people, because it would be difficult to breathe. It would be difficult to wear glasses or stuff like that. So they would prefer their nose to be open, but not really in a sense of survey or research. No, I think it would be probably interesting.
Great, thank you. We have a question from Zelalem Makaria as well. Zelalem, you can go ahead and speak.
Thank you very much, Laura. This is Alalan from GOHi. My question is, like with this COVID-19 pandemic, we've seen like several innovation, even with the vaccines coming in such a speed, but I don't get why getting the N95 masks out in huge quantity and be able to distribute them was a challenge. Is there particular drawback in producing a large amount, this N95 mask, and to reach to the public?
Yeah.
Thank you.
Thanks for that comment. I don't know really. I don't know the particularities surrounding the production of PPE at all. I don't, as you say, I don't know why. I don't know why that first recommendation was not to wear masks, right? It could have been, it could have been formulated differently, but that's what we had to deal with. Yeah, and this just tells you that that road from science to practice is really huge. And I think this, especially at the beginning of this pandemic, it was an epic failure of science to actually reach to the community. So we have to do better as scientists to communicate our science and ensure that the community and the end user is familiar with everything that we have so brilliantly produced so far, but we need to make sure that it's out there.
I think that's such a great partnership for thinking about these programs with community health workers too. I mean, because those are the people on the ground. And even having it be interesting, even as you're producing educational materials, to have them vetted through some groups that are working with the community to look at, like, because is this readable? Is this understandable? Is this gonna and will it kind of encourage behavior change?
Yeah.
I had a question. I've read some around, my background's in adolescent and psychiatry, child psychiatry, so I've not worn N95 masks, but I have read some. Yeah, I was reading one study just about how they're very uncomfortable too, and is that one of the factors that I just wonder if that's one of the factors of why that was not a push for wide distribution, that there was the sense that there would be even less compliance with those.
I don't really know. I haven't worn it, and I don't know what the barriers is or any specifics around the production. I just don't know.
Great. I have one question. So evaluation is a big component of all of this work to see whether or not what we're doing is effective. Do you have what are the biggest challenges in regard to evaluation, and how have you worked to overcome them? I know that's a broad question, but yeah, for both of you.
Well, I could start. I mean, I think, in my research, the evaluation is not a challenge because I develop a study, I develop my methods and my research plan and how I'm going to measure it and the variables. Coming into the community health worker program, it's a great program, and it was really in some ways very organically developed and worked with the community. And so I think when you think about community engaged work, the evaluation is more challenging. One is we're not often, nothing's under an IRB. So we're not we have to balance collecting private information too, and where that data is going and how to de-identify that, and what is, and in our case, what's educational data to use for more related to kind of quality improvement and tracking. So there's all those balances. The other challenge was that we were when I came on, it was a small group, 2 part-time people running the whole program, but so their focus was really on teaching and not much on evaluation. So some of it's just building the infrastructure as well, and some of the tools that we're using. But the opportunities are really vast, because I think we're impacting in our program the community and at an individual level, but potentially at a community level too. And this again is not my area of expertise around workforce development, but that you want to look at outcomes over time too. So did participation in this program allow you to get a job that increased your pay, but then if that job pushes has an impact on your whole family too, in terms of bringing income. And so there's these, I think, long-term outcomes that are really interesting to look at too. I haven't written a grant yet to do that, but I think that's probably the next thing some of the individuals on our team should be looking at.
Yeah, I would say depending on what intervention research is, the different challenges can arise. Attrition could be a challenge in your intervention study. I think the major challenge actually with evaluation is when evaluation is not done. Right, and we have seen a lot of times. Often we see intervention studies where that are not that have not included evaluation. Now, this at least in my field of food safety, but this is changing. And I think even the funding agencies are more and more requiring that the intervention research be done properly. And if it's done properly, it definitely includes it includes evaluation as a phase of the research. So you're evaluating acceptability, you're evaluating feasibility of the study, and all the details, as Susie also mentioned, cultural acceptability, etc., that you're testing with a certain population. So I think it is also a really interesting and growing field, because you can very creatively use new tools to apply to evaluation of your intervention. For instance, we're now trying the experiential sampling with some food safety intervention, and that is real-time sampling through the cell phone. And I'm very excited about that. I don't know how that is going to work because it hasn't been tried, but I think there are opportunities, and we always want to do better evaluation, right? We can always do better. Like when you are in a microbiology lab, and you can always improve upon your methods and include new methods and more accurate methods. This is how you do in behavioral research as well. You always improve upon your evaluation and your methods.
You know, I wanted to add one thing to that is a lot of my work I do is around intervention research and fidelity assessment. And so that the idea of that what you've planned is being done. And so that's so integral to kind of the validity of the intervention. Yeah. I'm also involved in in a lot of implementation research in science, and this just might be interesting to this group. A society that I serve on the board it's called the Global Implementation Society. It's a young society, but it's really across sectors. A lot of the implementation work has been in the healthcare setting, but this it's a pretty broad group in terms of the work and the research that's being done. And part of the key too is that this group engages implementation practitioners, researchers, and policymakers. And so it's a nice group that is interested in kind of the broad application of these of science.
Yeah, and it's so important to be inclusive of these stakeholders. There are some questions in Q&A threads.
Thank you. So we have some questions from Dr. Wang. She said, thank you both Sanja and Susie for your excellent presentations. Question 1, we have seen less influenza this season. It is likely multifactorial, but is there a possible public health messaging that could be sustained beyond COVID-19 for other respiratory diseases?
I think so. I think so. Not only public health, like wearing masks when you do not feel well and you are sneezing and coughing more than usual, or having flu, or think you might be having flu. That definitely should stay. There is no reason, as I mentioned earlier, it's preventing droplet transmission, and those droplets are carrying whatever one might have to offer. But also, not only public health, but also I'm thinking food safety. There's so much spillover that we can cash on for this hand washing, because finally, people are hearing us. We have been saying you need to wash your hands in any step of the food preparation, and that has been probably the most simple and would be most effective thing that they can do, but it's really the least complied with. And so for various behavioral reasons, we have noticed. So I think there's a lot of spillover. There's going to be definitely some negative spillover of on food industry. But this, wearing masks, washing hands, those are the preventive strategies that are effective against any infectious disease.
Great.
I could answer the second question, is about what the CHW program has done for non-US born individuals. We've actually had a lot of individuals within the non-US born immigrant population complete our program, and that's been actually really important because we have some large immigrant groups in Columbus. And so they do have to have fairly good English, because we do not have multiple language providers for the training, although the program requires a high school diploma. So it is not a high level training program. And the other thing is we do a lot of work with all of our participants to really make sure that our goal is for them to successfully complete the program, that they can then work with the communities that they live with. And so we do a lot of support in that way. So even like if they can speak and understand English, but some of the writing is problematic, more challenging for them, we work with them. So that's we're not writing papers. We're not we're doing a lot of skill building with them and for them.
Excellent. Thank you. All right, we'll take one more question for our final comments. We have a question from Dr. Getnet. You can go ahead and ask your question.
Thank you, Dr. Benkley, and great presentations indeed. And I want to hear your reflection, Dr. Sanja, on I was very impressed when you mentioned that you were working with a WHO affiliated groups on the mask and related issue. And I wanted to hear if you also have a plan to do the same on that wonderful work on the visually impaired, supporting the visually impaired, educating them, which is very impressive, award-winning, and your plan on expanding on that one. The other point that I also want to hear a reflection on, also on there is a growing myth on the type of mask you use and being hypoxic. I'm just curious if you have a plan to work with the industry, with your research finding on which ones will impair breathing and and beyond. So on those 2 points, great presentations.
Thank you. So visually impaired and blind, this is a very important question because there's just so little available for this group. And also I have to say always very little funding available, because this group of people only presents very small proportion, up to 2% of the population. So So there's never enough funding for research with visually impaired, but we're here to develop. And as I said, I partner with Dr. Tiffany Weil. She's in education studies, and she is a person that works with visually impaired, focuses her research on STEM for visually impaired and blind. And we have worked together. I have to say this module was the first of the kind that was produced for visually impaired, and definitely there is a plan to move globally and work with organizations in Europe and around WHO. There are different organizations in global organizations that are supporting materials for visually impaired and blind, and there is a plan to work with visually impaired communities on long-term basis. I do not have plan to work with industry on the masks. I think this experiment was very timely, and we showed very interesting data and needed data, but I do not have a plan as of now to work with industry to produce the textile. I'm not a textile specialist. We do have in our college, in our department, we do have a section that deals with fashion and textile, but I'm also not a virologist, so there. No plans for now. Who knows?
Great. Well, I will hand it off to Dr. Gabrays for any closing comments.
Thank you, Laura, Sanja, Susie. It's really wonderful panel and lots of useful information on behalf of all Global One Health Initiative. Thank you so much. I just want to give a couple of comments. Number one is for many attendees who are currently PhD fellows and future scientists, I can't stop keep thinking, 10, 12 years ago, Sanja was a PhD student and now a wonderful scientist and associate professor doing such in-depth work. Really very much appreciate all the scientific work. Susie, we just met, but nursing, education and human ecology, a number of areas are critical for global One Health. One Health is no longer just zoonotic diseases and veterinarians and physicians or something like that. It's much broader. So I think today's sessions makes that input that really, all the inputs you gave us, tells us how broad and interconnected our planet is. One of the additional dimension, and I would like to pick as a surprise, Dr. William Breitenstein, who is a political scientist who is with us and Global One Health Initiative's external advisory board member. He and I were in a large conference in the last 3 days, starting from Monday, really discussing lots of this interconnectedness and how higher education, we need to be embracing all these SDG goals and the current pandemics and social injustice. Many things, Susie showed a wonderful National Academy circle that really is wonderful connecting that. And thank you, William, for joining us very much. And really that dimension is much broader than health science and agriculture, right? So the political dimension as well. So Dr. Breitenstein and our external advisory board is trying to communicate that, the dimension of global One Health using a white paper. We're working on that, and GOHi leaders also are publishing this interconnectedness and the paradigm for the future. But I just want to say that, and thank you all so much, and this is very useful. So look forward for the next session. Thank you, Laura.
Thank you.
Yeah.
Thanks,
Great,
everybody.
Thank you.
And I was also going to add, Dr. Ilic made me aware that John Oliver also recently discussed One Health issues in his, I guess, season premiere. So we can sort of pass that information around and try to get that posted on our website as well. So thank you so much to both Dr. Ilic and Dr. Breitenstein for your wonderful presentations. We will look forward to seeing everyone in March. So thank you so much.
Wonderful. Bye.
Thank
Thank
you.
you for inviting us.
Thank you.